Immunizations is a really tough topic, and there's a lot of heated discussion, particularly in the media, of what to expect, how we can make recommendations, and how we can best inform our patients. And today it's meant mostly to be informative of the quality of evidence that exists in making the recommendations back to you. My name is Tracy Frech. I'm at the University of Utah in the Veterans Affairs Medical Center in Salt Lake City. It's nice to see several friends in the audience, and I, again, appreciate everyone who came today. So I think the importance of immunizations falls under the topic of healthcare maintenance. And so this is the act of encouraging each individual through both patient and family education to take responsibility for disease prevention and health promotion. And while it doesn't perhaps project as well, these topics oftentimes are covered in conferences like this, where we want to educate patients on how can we stay healthy and well. And many parts of healthcare maintenance are not controversial. So this includes eating healthy, this includes exercising, making enough time for self-care. Immunizations does technically fall under that healthcare prevention or healthcare maintenance topic, but it has a little bit of a harder conversation for you to perhaps have with your physician because there's fear that you're going to have an adverse reaction. So we would say with eating healthy or moderating alcohol, those are things that make sense and seem easy healthcare maintenance topics. Immunizations, maybe not so much. But they become a really important conversation to have when you've been diagnosed with chronic disease. And that's perhaps, I think, for patients, the hardest part of getting a diagnosis of systemic sclerosis is that life-changing moment that you realize, I have a chronic disease that I really need to understand how to stay well. And immunizations very much fall in that discussion. So chronic disease means that you have long-term management needs that both need to address both the physical and mental aspects of a health condition, but it also means that we need to really understand everything you can possibly do to stay well. Now, typically when we talk about health, we're really talking about having enough time for regular activity, good nutrition, and adequate wet rest. And I oftentimes tell my patients, think of it as if your doctor just gave you a prescription and said, you need to prioritize yourself. That means you need to tell people no or make your job schedule better so that you now have time to do those things our mothers told us were so important. And your health is going to be really affected by your daily symptoms, how well you're just overall feeling, and if you're able to do your activities of daily living. So preventative care in all aspects is allowing us to do those activities better. And so immunizations actually do fall in that, because if you do get a serious infection that could have been prevented by an immunization, we could very much all agree that that chronic disease suddenly changed and is harder to manage. So with that is the background for why we're talking about immunizations. Let's talk a little bit about why there's controversy and how we can understand the data. So in general, vaccines are categorized as live or inactive. So that's always your first question when you are getting an immunization. What type of immunization is it? Now, inactive gets a little tricky, especially if you get on the internet, because there's all these other terms that come associated with that inactive. Toxoids, that sounds pretty scary. Modified proteins, that seems sort of like a lab-based monitoring trick. How do we wrap our head around what exactly that means? Essentially, we're taking a part of that infection that is not infective and trying to get the immune system to look at it and recognize it. And why we want to do that is shown best in this diagram. The first time your body sees something that's foreign, not self, it reacts to that with a primary immune response. And that response means that your body starts making antibodies against that foreign substance so that you can fight it off or clear it. Well, if you see that same substance in the future, your body has a memory, so it can then attack that same substance with greater response, so it comes on faster and it goes higher. If your body can recognize and clear that infection before it sets up shop in your body and starts off the inflammatory pathways, you don't get as sick. So that's the vaccine thought process and why these are important. There's limited evidence that indicates inactivated viruses generally have the same safety profile in immunocompromised, so those are patients whose immune system's not working as well, as in immunocompetent individuals. And that's really where all this controversy lies. Whenever you have limited evidence, you can really argue fairly strongly on both sides. Importantly, the magnitude, so that upswing of the second exposure to antigen response, the persistence of that response may be reduced or absent in immunocompromised patients. So that's why some patients argue, well, I don't want to get the immunization because I'm not going to have as a robust response if I am exposed to that infection. The counter argument, of course, for that is any response is better, and if there's no harm in the vaccine, if you get any response to that antigen, that's a good thing. Inactive vaccines, this is a real good take-home message. There's some real practical tips in this talk, and I think this is important. You'll hear me say this a couple of times because I did want you to understand this, that inactive vaccines should be administered greater or equal to 2 weeks prior to planned immunosuppression. And that's really important because many people have gotten their screening pulmonary function tests and they do not have interstitial lung disease. They've had their lab monitoring. They don't have inflammatory muscle disease. They've had hand x-rays or joint ultrasound. They don't have inflammatory joint disease. And their skin is not changing, so they don't have an indication for immunosuppression for their skin changing in systemic sclerosis. And so that patient may leave the office and say, oh, this is a great visit. I don't have an indication for immunosuppression. But that is a real opportunity at that appointment prior to receiving any immunosuppression to have that conversation with your doctor about getting your immunizations up to speed. That in case in the future that changes, you've received that immunization and you're protected. Lastly, live vaccines should not be administered greater than or equal to 4 weeks prior to immunosuppression. And you'll see the strong and low in the parentheses. The strong is the strength of the recommendation. So this is where experts review all the data and they sit down and they say this how strongly they feel. They kind of hash out the details of the risks and benefits. And then the comma means the quality of the evidence. So when we see low, we just don't have enough evidence to really strongly give you the data to show that this is the right recommendation. But I think it's important for everyone, particularly if you travel a lot, to remember that that live vaccine prior to traveling for greater than or equal to 4 weeks before you start your immunosuppression. And then if you've gotten if you started your immunosuppression, you really don't want to get it after that. So when we talk about live and attenuated vaccines, it's easier if you see the names. So here it's listed here. The live vaccines include varicella zoster, Zostavax, intranasal flu, measles, mumps, rubella, yellow fever, and then more commonly in the travel clinics or for folks that are living abroad, oral polio, typhoid, smallpox, BCG, and rotavirus. So those are all considered live or attenuated viruses. What about the immunization schedule for children? This is an important topic in an adult audience, mostly for folks that have received transplant. So after an autologous stem cell transplant, remember, all that memory that your body had is now gone. And so if you've had an autologous stem cell transplant, it's worth to go back to that pediatric schedule and discuss that with your provider on getting your immune system back up to speed. The key facts, though, for our immunocompromised adults are really listed in these 4 main points. Firstly, you should receive all scheduled inactivated vaccines because of the risk-benefit ratio. Some vaccines need to be given before the immunosuppression is started. And so we really talked about even those visits where everything's going great and your doctor's not making any changes. If you're not on immunosuppression, that's the perfect time to have this conversation. And really, the level of immunosuppression determines what vaccines are appropriate. And we're going to have some slides on that. And then, as we talked about, when you start immunosuppression, it may affect your response to that immunization. Well, what are immunosuppressive meds? Those medications that are commonly used in systemic sclerosis with clinical trials are shown here. I will point out there's ones that are not listed, and those include drugs such as abatacept or tocilizumab or Rituxan that are in either clinical trial or have recently been in clinical trial. All of those medications affect your body's ability to respond to that immunization. And so also I'd like to point out, if you're thinking about doing a clinical trial, it may be a reasonable time also to speak about immunizations before you start on that clinical trial. In addition to the kind of routine immunosuppression monitoring that you receive, and for folks that weren't in my lecture yesterday, we talked a little bit about this. You should be aware, if you're taking one of those medications, you really can have a lot of power by keeping a notebook in your that you take to all your appointments, and either have your last complete blood count, which is screening for marrow suppression and an elevation of your white blood cells, which are your infection-fighting cells, your comprehensive metabolic profile, which is looking for liver or kidney changes, and a urine analysis. You have those labs with you, and you're certain that you're checking them at the right frequency. And the reason I point this out is oftentimes orders are placed into a chart and the patient knows nothing about them. So it may be the doctor prescribed the medication and gave you monitoring labs, but you didn't know you were supposed to get them. And so I think sometimes when we go into this completely electronic age, things get missed. So I like patients to be empowered. If you're on an immunosuppressive med, you know the name of that, you know the potential side effects, and you know how often your lab monitoring is being done. But pertinent to this talk, before starting immunosuppression, it's mandatory to make sure you don't have certain types of infections. So oftentimes your doctor has screened you for these, but you didn't get the results. And so it's very reasonable next time you're at the doctor's office to say, hey, I'm on methotrexate. Did you screen my hepatitis B and C? I'd like it for my records. Your tuberculosis screening is more commonly done on biologics. Those are the TNF-alpha inhibitors, but you oftentimes may get that routinely in the rheumatology practice. And then pregnancy testing is done in women of childbearing age. Please. So those are Enbrel or Humira. They're used for inflammatory arthritis. Some of our patients who have inflammatory arthritis have seen those medications, but it's not a standard treatment that's used for systemic sclerosis. Please.
Back to where you're talking about pediatrics.
Yes.
So my son was diagnosed at, say, 13. He did not get HPV. So can he go back and get that? Some doctors say yes, and some doctors say no.
So he can, and we're going to break down each of the immunizations, each of the classes of medications, or immunizations, and talk about scenarios of getting them, but the short answer is yes. And then also this immunization review is important, and that's where if you have your immunization card, that is fantastic to bring to your doctor's appointment. And the reason is they can put that in the Epic medical chart. And so then it's always with you. And if you don't want to carry your card, you can then ask for a printout of that sheet from your medical record, or you can also get access to it. So now, great question, and I'm sure most people are asking, she's going to start talking about immunizations. That's the background. We're going to now go through each of the immunizations that are recommended for patients 19 years and older. And I'd like to point out, when we're talking about the vaccines, these are the typical ones in the US that we're talking about. The abbreviations for this chart I've listed out on the other side. Oops. So this is where we, immunocompromised, excluding HIV infections, we start to see some contraindications. And again, we're going to go through each of these immunizations, but I'd like to point out it's important if you're on immunosuppression and someone recommends MMR, varicella, or a certain type of shingles vaccine, the Zostavax, that you are aware those are live vaccines, and we don't give those to patients that are on immunosuppression. It also is important to realize that if you are on hemodialysis, so if you've had a scleroderma renal crisis, your immunization recommendations also change. And so you can see here that we start to get into these areas where the purple, recommended for adults with other indications, those conversations about hepatitis A becomes important, and also the meningococcal vaccine. Additionally, with heart and lung disease, and that's, again, we get into the concept of once you have a change in your systemic sclerosis, so you've developed interstitial lung disease, re-talking to your doctor about your immunization schedule and whether you are up to speed becomes important. So again, it's back to that prevention model where we're doing everything in our power to stay well. Please. So that's a great question. It does not, it's an immunomodulator, not an immunosuppressant. I'm sorry, I should repeat it just for the audience. The question was, is Plaquenil or hydroxychloroquine an immunosuppressant? It is an immunomodulator, not an immunosuppressant. What that means is it changes the pH of your immune cells so that when your body is removing those cells, they sort of die in a more proper way. With inflammation, there's some concept that you have a lot of inflammation. The inside of a cell, the cellular material is shown to the immune system, and the immune system may develop autoantibodies against self just by virtue of cell turnover. Plaquenil or hydroxychloroquine changes that pH of the cell so that it dies more properly and there's less inflammatory turnover. That kind of analogy is that it sort of helps the garbage man of the body work better to process inflammatory cells, but it does not suppress those cells from working. So it is not an immunosuppressant, but an immunomodulator. Long-winded for it does not put you at risk for infections. You're welcome. And so here are some good guidelines that I think is very worth, and I've put the reference there so you can print it off. It's very worth having in that little binder that you take to your doctor's appointment. And it talks about sort of the differences between planned immunosuppression, low-level immunosuppression, and high-level immunosuppression. And the real key there is that low level means daily or low dose or intermittent corticosteroid therapy. And we've talked about that. If you are taking low dose corticosteroid therapy or high dose, you're going to be monitoring your blood pressure. And in systemic sclerosis, we really worry about scleroderma renal crisis. So not only are you going to ensure that you're talking to your healthcare provider about your immunization schedule, but you're going to be talking about your blood pressure. We also consider biologic immunomodulators, methotrexate and Imuran, to be low-level immunosuppression. Then with the high level, that's corticosteroid therapy over a dose of 20 milligrams. And that includes those TNF blockers, so that's the Enbrel Humira. It's used more for rheumatoid arthritis or psoriatic arthritis, or rituximab. And so I like to point that out there, that since that's being used more in systemic sclerosis, that distinguishing factor helps you understand how we can think through whether you should get an immunization or not. Here's it shown in a much better, I think, easier digestible manner. So if you're on a high-level immunosuppression, so again, that's the rituximab or high-dose prednisone, you want to talk to your doctor prior to starting it about getting these Prevnar or Pneumovax. I go over this in the next 2 slides on the schedule, so you don't have to remember the verbiage after that. And then you need to remember you're not going to get the Zostavax, varicella, or the MMR. Now, if you're on the low-level immunosuppression, then you can get the Prevnar, the Pneumovax. You can get the Zostavax if you're over 60, but we're going to talk about why Shingrix would be better. And you can consider varicella. And I had a really excellent question before the lecture started. And someone said, well, why does everything change at age 64? Why do we start thinking about this differently? And the reason is, as you age, your immune system doesn't work as well. It's something called immunosenescence. So as you age, that robust response is not as good. So the risks of giving live vaccine start to be more of a real concern in an older population. Please.
Would CellCept or mycophenolate mofetil fall on there?
It varies depending on dosage. So that's the hard thing. And that is really where the research hasn't been done well enough on all the different standard doses. You sort of say, well, why methotrexate, Imuran, all this data? It's because the rheumatoid arthritis disease population has had so many years of treatment that you can retrospectively look at large populations and dosing and categorize those better. The newer agents just don't have the data. But, if you leave here with one sort of pearl, I think the key is trying to get them up to speed before you start any drug. And please.
But if you've already started these drugs, and say you're on 3 grams of CellCept daily, that's, I think, a high dose.
Yes, 3 grams would be your max dose.
So would that be on the high level?
So I would consider that a high-level immunosuppressant, yes, with the absence of data. Now, again, it may be in 10 years from now, we look back and say, actually the mechanism of CellCept wasn't like Rituxan or a TNF inhibitor, so it is safer. But you're absolutely right. If you're on the max dose of an immunosuppressant, erring on the side of saying that's a high-dose immunosuppressant.
So then being on that high dose, does that preclude you from being able to take HPV vaccine then?
So no, we're going to talk about HPV. Sorry, it's coming. These are live vaccines that are the concern. You're welcome. So here is the most common scenario, and this is kind of speaks to those questions, which I think are excellent. This is fine and good if you haven't started immunosuppression, but if you're already on immunosuppression, how do we backtrack and figure out how to navigate whether you should have the vaccine or not? And so some take-home messages that are true in everyone are that all patients only receive 1 lifetime dose of Prevnar 13. And this is one I think is super hard for patients because you say, I don't know what I got. I went to the doctor's office, they gave me a shot, I didn't get a record on it. And so the pharmacist at our clinic will actually call and try to track that down because we do want to make sure that we're immunizing patients properly. And the kind of standard dose would be you get your dose of Prevnar 13, you wait 8 weeks, then you get your Pneumovax 23, and then at least 5 years apart for a total of 3 doses. This is like the best strategy for pneumococcal prevention. So for folks who have had no immunizations, this is what you can show your doctor. And there's a really nice, all the data I'm showing you has links to the sites from the Center of Disease Control. Shown in maybe like an easier way, because I like simple. You sort of say, okay, Pneumovax 13, 8 weeks later, 23, 5 years apart, then 5 years apart for the total of those 4 doses. Well, here's where you get into, well, what if my doctor messed up and gave me the 23 and not the 13? How do I backtrack and figure that out? Well, the key here is that 23, you wait 1 year until you get your Pneumovax 13. And this is something that actually I think patients really are empowered to talk to healthcare providers. These nuances sometimes get hard for healthcare providers, and I give the disclosure. We have a pharmacist who does all of our immunization training and lectures. So she works with patients to make sure they get on track. The other scenario is, let's say you've had your 23, and this is actually a really common supposition. People say, well, I have the 23, doesn't that have the 13 in it? It's like better. And the answer to that is no, you need them both. But if you've had your 3, you still have to wait a year from the last 23 to your 13. Same thing, let's say you got 2 of your 23 and then that 13 snuck in there. You can wait 8 weeks before your next 23, but the 23 still has to be 5 years apart. And this is just to maximize your response, your immune response to these vaccines. Lastly, is sort of the same scenario. really highlights in patients that are over 65 years old, you only get 123 after age 65. So after age 65, you're just getting one more dose of those medications. Now we're going to talk about the shingles vaccine, and this is a really hot topic, particularly in the media. And for anyone who has had shingles, I'm sure they're shaking their head in the audience and saying, this is so awful. It is a painful blistering rash, and while it typically scabs over in 7 to 10 days and can clear within 2 to 4 weeks, you can get this post-herpetic neuralgia, which is incapacitating, sometimes nerve pain in the distribution of this rash. And that can last for many, many years and can be quite devastating to a patient's quality of life. So the important thing to realize is your risk of shingles increases as you get older. The sort of old teaching is 80% of people will have had shingles by age 80. 2 vaccines currently are licensed and recommended. This was a real game changer in our immunosuppression world because, as we talked about, Zostavax was the primary vaccine and was a live virus, and so we couldn't use it in the immunosuppressant clinics. But this new recombinant Zoster vaccine, which has been used since 2017, you can use in immunosuppressive patients. And it's recommended by the Advisory Committee for Immune Prevention as the preferred shingles vaccine. But this is another key statement because you may go to your doctor's office and they don't have Shingrix. They say, well, if you're healthy and you're 60 years or older, you can still get the Zostavax. But we really have our patients try to advocate and say, well, I may go on immunosuppression in the near future. I have an immune system that doesn't work so well because I have an autoimmune disease. And so while there's somewhat of a shortage of Shingrix, we do feel that our patients benefit from that. There is, this is from the CDC though, if you're allergic to Shingrix or you prefer it and you request immediate vaccination, then you can have this discussion, please.
If you've already had shingles, can you still take that?
You can still get the Shingrix, yes. You can still get the Shingrix. Yes.
If you've had one, do you get the other?
No, the answer to that is if you've had the vaccine, so the question was, if you've already had the Zostavax, do you need to get the other one? If you have, and this is where your doctor may check to see if you've had a response. You can get blood tests to see if you've been your exposure. But once you've been immunized as long as you haven't had a transplant or something that's changed the underlying immune system. So our real take-home message from Shingrix is that this is the herpes zoster subunit. So this is an inactivated vaccine. It has very good efficacy, and that in general you'll receive 2 doses 2 months apart. And while it was not studied in immunocompromised adults, it is being used in the immunocompromised population with thus far no concerns. What about flu vaccines? So flu vaccines help you develop those autoantibodies that will, about 2 weeks after you've had the vaccine, so that you can fight off the flu for that season. These antibodies provide a strategy for your immune system to recognize many parts of what's thought to be the most common flu virus that will be seen in that season. So you have people that's at the Center of Disease Control that predict which variety of flu is going to be rampant in that flu season, and then they develop the vaccine to target about 3 or 4 of those viruses. And this is why sometimes you hear in the media, we got the flu shot right this year, or we didn't get it right. It's because that prediction model of what can we give you to help fight off that flu if you're going to see it. There are different flu shots that are approved for different age groups, which we're going to go over in the next slide. There's a lot of hype in the last couple of years, particularly in the media, about what about trivalent versus quadrivalent flu vaccine? Do I need the high dose? How can we think through? So let me just explain why it's somewhat confusing. And oftentimes when you go and you get the flu shot, you may not even know what type you're getting. And so I oftentimes ask patients just if they're going to get it at the Walgreens or they're going to get it at a supermarket or a health fair, just to ask what type they've received. So Afluria is a one standard dose. It's trivalent. It's grown in eggs, and that's why they always ask you if you have an egg allergy before you get this vaccine. And it's usually given by a needle for folks, for kiddos 5 years. 5 years and older, and then a jet injector for the adult population 18 to 64. The trivalent fluad has an adjunct with it, and this is approved for folks 65 years and older. We'll talk about that, but that adjunct is supposed to get your immune system a little bit more revved up, so it's helpful for the older population when we talked about that immunosenescence may have taken place. The high dose has a higher equivalent of that trivalent. And then there's these quadrivalent flu vaccines that have come out that have more in them to activate the immune system. Vaccines are not recommended that have been made in eggs for those who have an egg allergy, and so that's why you always sign that on the consent. And then there is a cell-based flu vaccine that's available mostly in hospital clinics as an alternative for egg-based manufacturing. So if you have an egg allergy, you no longer have to say you don't get a flu shot, you just have to get the right type. The Fluvilex quadrivalent contains the virus grown in cell culture and has been approved for folks 4 years and older. So for our kiddos too, that egg allergy vaccine exists. So the important thing to realize is that the data from the clinical trials comparing the trivalent to the trivalent high dose among persons 65 years and older showed a stronger immune response to that high dose. So that was really where it hit the media and said, if you're 65 or older, ask your doctor before you get the flu shot whether they have the high dose. And again, it has this extra antigen in it that helps get the immune system revved up. Patients oftentimes will ask if they're not 65 and older, should they get this vaccine? It's really hasn't been studied well enough. So the Advisory Committee of Immune Prevention doesn't recommend this high dose over any other seasonal vaccine at this time. And they don't have a preferential recommendation on any specific vaccine product. So all of that hype, we just don't have enough data on what the best flu vaccine is. And the real take-home message is don't delay. Let's say they don't have the high dose, and I saw this a lot in clinic this year. A lot of folks 65 years and older said, well, I'm not going to get the flu shot till you have the high dose available. And the pharmacist spent a lot of time saying we should just give you what we have so that we can prevent flu. It's not clear when the more high dose is going to be available. There is some caveats with the intranasal flu vaccine. This is used generally in the pediatrics clinic. And there's some important points about not receiving this nasal flu vaccine, particularly if you've had an allergy to any components of the flu vaccine, and that's a real take-home message because people think, oh, well, I had a big reaction to the shot form. I should just get the nasal form. And again, it's a contraindication. In kids receiving aspirin-based products, there can be a very serious life-threatening reaction, so that's a pretty important point. Patients with immunosuppression, this is not recommended, so to the pediatrics clinics, that would be something you would decline. And if you've taken antiviral drugs in the last 48 hours, you wouldn't want to take this type of flu vaccine. And then if you're caring for severely immunocompromised persons, you need to delay 7 days of contact after getting this vaccine. And we'll have a slide on caregivers. So the best way to prevent the flu is the flu vaccine, and they should be started as soon as you could possibly get them. And I often tell patients, you want your flu vaccine before Halloween. So if you can remember to try to get that shot before flu season starts, that's the best thing. But I also want to have one slide on the antivirals because patients ask about this all the time. Remember, there's 4 FDA-approved antiviral drugs, and they're recommended by the Center for Disease Control. The most common one was Tamiflu, and it's a pill or a liquid. There's some newer ones that I think it's important for scleroderma patients to know about. There's a powder version that's inhaled that is not recommended for folks with breathing problems. And then there's an intravenous form that's been done in the hospital. And the take-home message is there's not as much data on these newer drugs and how well they work in our population. But I will say this, it is very reasonable if you have a family member who has flu to call your provider immediately to request Tamiflu. Put that on your list of things that you would say as an emergency. You want to make sure we're preventing the flu, even if you've had the flu vaccine. So even if you have the flu vaccine, you still can take these drugs, just preferably not 48 hours after you had the flu vaccine. The next sort of controversial area is tetanus. So tetanus and tetanus with acellular pertussis are the two versions. Tetanus you generally can remember getting because it makes your arm hurt really, really bad. And you get that booster about every 10 years, and usually on your EPIC chart, your doctor will remind you. This is a great opportunity to ask if there's a pharmacist in the clinic, and so if you have any vaccine questions, they can help you get your record up to speed. The acellular pertussis, generally pregnant women will get it during pregnancy, but the real caution here is a history of seizures, and that's why usually in the adult population, the tetanus is given alone without that acellular pertussis. I will point out here, the most time you're starting to talk about tetanus with your provider is if you've had a wound. And it does change. There's two things that change when you've had a wound. One, is it a clean wound or is it a dirty puncture wound? And then it really changes by age. And so, the tetanus immunoglobulin is sometimes given in folks less than 64 years if they've had a dirty puncture wound, and that is given in the emergency room setting. So here's the slide I promised. So here's the human papillomavirus. So this was a real revolution, actually, for healthcare because clinical data showed close to 100% protection against cervical precancers and genital warts. And studies have demonstrated no decline in protection over at least 10 years. And why that's so important is unlike the varicella vaccine, where there's concern if you got the vaccine and not the actual rash, would you not hold that immunity? This vaccine seems to be effective and is most effective if given before the exposure to human papilloma. And the reason, so I told you I was going to get back to your question. The reason while sometimes folks will say, well, it's too late, you can't get this immunization anymore, is there's this window of opportunity in adolescence where the immune system has the best response to that vaccine. And so that could have been where, well, you passed the window of best response. It's still, we will oftentimes use this in our clinic, which is adult population, in 20-year-olds that are going to start methotrexate. And again, it's because of the efficacy in preventing cancer. There are different licensed vaccines. So there's the bivalent, quadrivalent, and 9-valent. So the type of vaccine varies by the manufacturer. And what that really just changes is your dosing schedule. So you want to make sure that if you're doing this one series, you get it at 1 month as opposed to 2 months. Also, sensitivity to Lasix is something to latex is something to discuss with your provider or yeast. But it is a safe vaccine. So my guess is even on immunosuppression, the thought was, well, you've missed the window, you may not get that robust response, but it's not a contraindication. Will he not respond to it? So that's where that response won't be as good. Now, you could argue, would it be better to give it when he's on a lower dose in the future? And that's maybe what they were going at, but it's not dangerous. So that's really where, it's the risk benefit.
I don't think that there's going to be a lower dose anytime soon, so I would just get the shot.
But the other thing that, yes, I mean, the correct answer is yes, you can know that you've got it and that your response can be monitored subsequently. Again, those blood tests can be helpful.
If it was something where you took it down to say a day,
So that is a good question. I think we can really borrow upon the that idea of at least 2 weeks before starting immunosuppression. So the thought that you want your immune system takes about 2 weeks to respond. So if you go on a lower dose, you get the immunization. You wait 2 weeks after the immunization, then you go back up on the dose. But this is what's so tricky is it's kind of guesswork. So I wish I had the data or the quality of evidence to support those comments. No. So briefly on the hepatitis B, it's a busy slide, but I think it's something that most folks have been screened for hepatitis B. Just some kind of points on this. If you have hepatitis C, you absolutely want to be immunized against hepatitis B. If you have cirrhosis, also important. Alcoholic liver disease, but what I oftentimes tell patients is autoimmune liver disease, and folks ask about this commonly and say, have I been screened for this? If you've ever had a high-res CT of the chest, and in the comments of your liver, you can check the report under liver, if there's steatohepatitis, that means fatty liver, that's something worth having a conversation with your doctor about. Furthermore, if you've ever had laboratory values of your ALT or AST, those are called transaminases, and those are elevated more than twice the upper limit of normal, that's also something that's a clue that your liver might be not be totally happy. And if your liver is sick, protecting it against an infection becomes critically important. Biologic therapy, so that is like Rituxan, Rituxan or the TNF inhibitors that we talked about, those have had reports of reactivation. And so before you're initiating a drug, you're going to have that conversation with your doctor. Have I been screened for hepatitis B? And you're going to get these 3 labs, and that's why I have it on this chart. There's a Hep B surface antigen, an anti-Hep B surface antigen or a surface antibody, and then a core antibody. And what those basically tell you, if you've had the core antibody, if that's positive, you have been exposed to hepatitis B, the real virus. If you have the surface antigen without the antibody, then you're actively infected. And so this chart can kind of help you navigate. Those are the general ones that are sent, kind of where you are at the spectrum. Most of you probably just have the surface antibody and nothing else, and that means you've just been immunized, okay? That can get kind of confusing when you get your labs and you see Hep B surface antibody, oh my gosh, I have hepatitis B. No, that means that you were immunized and protected.
I'm sorry, Dr. Frech. You're talking about the anti-HB.
Yeah, the one in the middle is the antibody, yes. And it's the S stands for surface antibody. And so the immunization gives you a protein, and then you get a surface antibody to that molecule. And so that's something important for you to ask your provider, particularly if you're on immunosuppression. Have I been immunized to hepatitis B? And these labs will come back, and you can look at them. What about Hep A? And I think Hep A is interesting. That advisory committee on immunization practices basically reminds us, and I'm sorry for those who get queasy, this is a preventable vaccine, but it comes from the ingestion of fecal matter. That's why when you travel in countries and you eat food and you get hepatitis A where there's not great hand washing practices, this is the one that's the foodborne illness. The infection can last from weeks to months, and the symptoms are like most liver disease. You can turn yellow, you get nauseated, and get abdominal pain. And the important thing, there's the recommendations are for children. They get them during their childhood immunization series. Anybody who's homeless or has unstable housing due to the exposure to sewer contamination. Anyone who's at risk for infections with the kind of standard ones listed there. But then here's the bottom one. Anyone wishing to obtain immunity. So by virtue of just being seen in a rheumatology clinic, if you'd like to have this vaccine, you can. There's 2 different ones available in the U.S. One is combined with a hepatitis B, and that's what patients oftentimes ask us, like, I'm going to start my drug, I'm not immunized to hepatitis B, can I get them both? And so your immunization clinic or your pharmacist can tell you if you have access to that. The single one is 2 doses, the combination is 3 to 4, and all are inactivated vaccines, so okay for us to take. For travel vaccines, every major hospital has a travel vaccine clinic. It's very reasonable for anybody on immunosuppression to meet with the travel vaccine clinic prior to traveling anywhere. In fact, I think it's great. The only thing I always ask patients to do if they have done that, to check back with me and make sure I agree and that there's not anything that I would say differently. But usually the guidelines for the Center for Disease Control are very strict. And the key is the yellow fever vaccine generally shouldn't be administered to immunocompromised patients. And we like to avoid typhoid, which is an oral live vaccine. So those two, if the travel clinic told you to take those, you might want to check back with your rheumatologist. But in generally speaking, they wouldn't do that. So this is for those who are maybe in the audience who are spouses or loved ones that are kind of concerned, I don't want to get an immunization that could potentially harm my loved ones. And so here is a nice article that reviews the safety of the live vaccines for contacts of immunocompromised patients. You can see mainly they go through influenza, measles, polio, rotavirus, typhoid, varicella, yellow fever, and zoster. And in most cases, the recommendation is to go ahead and administer to that immunocompromised person. But here is the key with that nasal vaccine. We've already covered this, but remember, if you get that, 7 days until that person interacts, and that includes someone who's had a stem cell transplant. And this is really important for grandkids, and you may not think to ask the grandchild's parents, when did they get their immunizations, did they do the live nasal vaccine, particularly if you're on a high-dose immunosuppression. And you can see that these are kind of strong recommendations on all of these. The other one I want to point out is that if varicella, if someone has open blister lesions, you want to avoid contact with that person until those lesions are healed. And then lastly, I'll just say for yellow fever, it's passed in breast milk. So, and there was child encephalitis by that breast milk passing to the infant. So if for some reason you're not on immunosuppression, you've had your yellow fever vaccine because you're going to travel, you don't want to breastfeed with that immunization. And kind of in conclusion, the last slide, and we have time for questions as well. The financial impact of immunizations is something that everybody kind of fixates on. We spend lots of money on hospitalizations that could have been avoided if we would have just done a better job with pneumococcal, herpes zoster, HPV, and hepatitis B. We really could, in influenza, we could prevent complications. But what I say as a healthcare provider, please check with your insurance company about whether they cover the immunization, because I always feel like the poor patients that are doing the right thing, they're trying to be preventative, and then Shingrix was not covered by their insurance company, and it was administered in the hospital by a nurse, so it was like the most expensive possible way to get that shot. So I always say, you're empowered to keep your list of immunizations, have that conversation with your healthcare provider, but make sure that doesn't add to your pocketbook. And that's please. Oh.
I'd also like to add that certain countries require the yellow fever vaccine. Don't make the plane reservations until you find out if it's required. They will not let you on the plane. You can't go. I don't know why you would want to go to the jungle if you're immunocompromised. Which is usually where the yellow fever is required. But don't buy your plane ticket before you find out.
That is a great point. And just because this is taped, I'm not sure if they projected your voice, I'm going to repeat that as well. So the comment was, don't buy your plane ticket to a foreign country that mandates the yellow fever vaccine before you've checked. So again, at that travel clinic, you're going to a place, you're going to see what the recommended list of vaccines. If it's mandatory and you can't get the yellow fever vaccine, don't buy the ticket. That's a great point. I'll add that to the talk.
You can also look on the CDC website if you have the ability to do that. You just type in the country you're going to, what cities you're planning to visit, or wherever. Are you going into the jungle? And you can look up whether it's required or not.
And that's a great point too, because sometimes in the cities, it's different than if you're going to be in the jungle areas. So the CDC does a nice job. So in conclusion, healthcare maintenance is a very important aspect of systemic sclerosis. And I really going to go back to the importance of self-care and healthy diet and sleep and exercise and all the things that can help you well. But immunizations are a part of that. On immunosuppressions, medications, that is a real change in care, and I really want to highlight that. If you're taking a medication that suppresses your immune system, you really want to know where your blood counts are running. You want to make sure that you know what vaccines are recommended. And then if you are, and I really appreciate that point, oftentimes if you're already on the medications, trying to backtrack and weigh the risks and balances, I think it's really important, are you going to be exposed to that infection? And if you are, a little bit of protection is better than nothing, and especially if it's not obviously an active vaccine. Keep your immunization records with you and know what vaccines are indicated, and all the links to the websites can take you there. And then your primary care physician and rheumatologist should work together to for prevention and wellness. And I just like to conclude on that point, because oftentimes I think you don't know who am I supposed to have this conversation with. And in our clinic, like I said, I'm a little spoiled because I have a pharmacist who's phenomenal, and she'll sit and spend time going through the immunization records and have these conversations and weighing those risks and benefits with the patient. But if your rheumatologist says, I don't really know anything about immunizations, you can find a pharmacist at a different pharmacy, and they generally are trained on how to give you immunization recommendations.